A 67-year-old gentleman is sitting in my clinic. He's already on triple therapy. His inhaler technique is perfect, his adherence is excellent. Yet, he has had two exacerbations this year. Now, a few years ago, I would have had very few options. But today, Gold 2026 gives us a completely new answer. And that answer is biologic therapy. Welcome, colleagues, and welcome to Pulmonology Read Aloud. We've all seen this patient in our clinic, and Gold 2026 update has given us a fundamental shift where we are looking at treating our COPD patients not just for their symptoms, but targeting the underlying pathobiology of eosinophilic COPD. So let's get started in this video where I decipher the biologics in COPD for you. Now, for years, COPD management looked like a ladder. You add LABA, LABA LAMA, triple therapy, and then nothing. Gold 2026 is the first time that this ladder has grown another rung. What we are going to see here is how Gold guidelines have now started introducing the concept of biologics in COPD management. In the form of a table and two short paragraphs, this year's guideline has shown how the future of COPD management will depend on lot of changes. One, looking at eosinophil counts. Two, correcting the basics. Three, looking at the 4M approach and treating the patient for his stability. When you look at the Goal 26 paper, and I have a video on Goal 2026 changes where you would appreciate that as far as the biologics are concerned, the guidelines have mentioned how eosinophilic COPDs, especially the ones with chronic bronchitis and recurrent exacerbations, have been shown in trials to respond well to two biologics, Dupilumab and Mepolizumab. There's also a paragraph which mentions that there have been certain studies done with Biologics where there has been no change in exacerbations. So, in a nutshell, these two biologics have come in the flowchart for COPD management. So, today, by the end of this video, you'll know three things. First, why biologics suddenly entered the COPD management. Second, which patient sitting in your clinic actually qualifies. And third, whether to choose Dupilumab or Mepolizumab. Now, coming to our case, Mr. R. Now, this patient is on maximal management. He's on triple therapy. He has eosinophilia. He has had two exacerbation. So keep these three facts in mind because they are going to decide the rest of today's story. They're going to decide how this patient will fit in the Goal 26 biological phenotype and where one of the biological may be considered. Now, while we often think of COPD as a neutrophilic disease, research has now shown that roughly 40% of our COPD patients exhibit type 2 inflammation, which is characterized by increased blood eosinophil levels. In India, we see a lot of patients with asthma and COPD also overlapping because we have a lot of smokers who may have been allergic or asthmatic to begin with. So, this is the key insight. We used to think COPD was one disease, but it isn't. And now we know that if inflammation is different, our treatment should be different. And that's how blood eosinophils have come out of just the asthma umbrella to COPD as well. So, what changed in Goal 2026 that brought us here? Goal 2026 showed us that instead of waiting for repeated exacerbations or waiting for them to become severe, requiring hospitalizations, even one moderate exacerbation has become a warning signal. One event, not three, not four, just one. So our threshold for action has become much lower, and we are looking at the concept of trying to stabilize our patients so that they don't have repeated exacerbations. Now, in this slide, which I have taken from my previous talk on Goal 2026, you see how the algorithm has changed. You have to ask yourself a question of whether your patient has eosinophilia above 300. You have to ask yourself a question if your patient is exacerbating despite triple therapy, because if he has, then he has entered the biological pathway. This is the slide which showed us in the 2026 document that the initial and the follow-up management of COPD has to be split. While initially we are concentrating on categorizing our patients into group A, B, and E, when you are looking at follow-up pharmacological treatment, you have to ask yourself if your patient is having persistent dyspnea, or your patient is having severe and recurrent exacerbations, because the management protocol here changes. And for your patient who's having severe recurrent exacerbations despite triple therapy, you have to consider adding the add on treatment. So let's look at this follow-up algorithm in a little detail. Does our patient fit in this COPD gold algorithm? Well, for our patient, he is having moderate exacerbations, which are 2. He's on triple therapy and his blood eosinophilia is more than 300. So that directly places him into this box of biologic therapy. But if our patient did not have blood eosinophilia more than 300, he would have been a candidate for roflumilast and azithromycin that can again be given in this patient. So we're looking at the chronic bronchitis phenotype. We're looking at the phenotype where the exacerbations are more, or probably the infections are also recurrent. So the first question of whether a patient meets the biomarker criteria becomes our major criteria for consideration of biologic pathway. The second question of adequate control of disease is clarified when we've already maximized the patient's triple therapy. Now, the first biologic option that we have here is Dupilumab. Dupilumab is a fully human monoclonal antibody. It blocks the IL-4 and IL-13 shared receptors. There were two main trials that were done for Dupilumab, including the BOREAS Trial and the NOTUS Trials. Now, the BOREAS Trial was the first one that showed a significant reduction, around 30% reduction in annual exacerbations in this population. But the question clinicians care about is very simple. Does it work for our COPD patients? And the trial showed that at the end of a year, these patients had much lesser exacerbation. Now look at this evidence which was shown in the Goal 2026 document flowchart figure. Here they mentioned the RCTs for Dupilumab, BOREAS and NOTUS. Notice how both of these trials had more than 900 patients, and they included patients who had a FEV1 post-bronchodilator 30 to 70%. They had to be of the chronic bronchitis type, and in screening, their eosinophils should have been more than 300. And this was common in both of these trials. Now, when you look at the rate of exacerbation, they did notice a significant, roughly 30% reduction in the annual rate of moderate and severe exacerbations. And they also showed an improvement in lung function to the tune of 83 ml in the BOREAS trial and 62 ml in the NOTUS trial. And they also noted an improvement in SGRQ scores. Now, this phase 3 double blinded randomized trial in these patients was done by using 300 milligrams of Dupilumab injection every 2 weeks. We'll come to the Mepolizumab part of it later. So, what did the trial show? It showed FEV1 improvement, it showed improvement in quality of life, and it also showed reduction in exacerbation. And that's exactly what we are looking at when we are treating severe COPDs. Same ways, the NOTUS trial also favored the same and showed a favorable safety profile, and thus these two are supporting the GOLD recommendations. The problem here, however, is the phenotype nuance because chronic bronchitis phenotype is very important and relevant when you're considering Dupilumab. The other biologic option given to us was Mepolizumab. We've all used Mepolizumab extensively in our patients with eosinophilic asthma and severe eosinophilic asthma, and we found really good results as well. So, Mepolizumab, which is again a monoclonal antibody targeting IL-5, directly inhibits eosinophilic inflammation. Here, three main trials were done: the METREX, METREO, and MATINEE Trial. And while the earlier trials like METREX showed a modest 18% reduction in exacerbation, the other trials, the MATINEE Trial, was a compelling case for its use in severe disease because it demonstrated around a 21% reduction in exacerbations, and it also showed a 35% reduction in exacerbation leading to ER visits or hospitalizations. And that's really impactful in a severe COPD patients. When we talk about the FEV1 and SGRQ, that has been varied improvement across the trials. But if it is keeping our patients out of the hospital, that is a big win-win because we are moving from an interesting science to practically applying it now. So Mepolizumab did show a reduced annual exacerbation. It also showed greater benefit in patients with severe eosinophilic counts, and this gave us the option of using eosinophils for biomarker-directed therapy. So coming back to the COPD 2026 guideline figure, which talked about Mepolizumab. Here, Mepolizumab was used again in the dose of 100 milligram once in a month or once in 4 weeks. So definitely the frequency was less than Dupilumab. And all the three trials had a good patient number with MATINEE and METREX more than 800 and METREO trial around 674 patients. Again, what were the inclusion criteria? The FEV1 post bronchodilator had to be between 20 to 80 with more than 300 eosinophils screening and more than 150 eosinophils in the previous year. Now, that's also very relevant because a lot of COPD patients might be on steroids on and off because of the exacerbations, and then the eosinophil level documented more than 150 in the previous year is good enough. The same criteria were applied to the other two. However, METREX considered more than 150 eosinophil for screening and more than 300 any time in the previous year, and same for METREO trial. Now here also we see a good improvement in the rate of moderate to severe exacerbations. But what do you notice here? The lung function improvement was not so significant, telling us that while Mepolizumab trials did show that there was a reduction in rate of exacerbation, the quality of life and the lung improvement was not as well improved as with Dupilumab. So Dupilumab definitely bore an edge over Mepolizumab based on these studies. So now, how do we choose and what do we choose? Now, the data is showing that only a specific patient phenotype can be taken for the biologic therapy. When we are talking about Dupilumab, it is particularly relevant for the chronic bronchitis phenotype. But we are also looking at someone who may have a poorer lung function and we need an improvement in lung function and poorer symptom scores. When you're talking about Mepolizumab, you may prioritize it when your primary goal is to reduce the healthcare utilization. You want to reduce the frequent hospitalization because it has shown a significant effect in exacerbation reduction, but not such a good effect in quality of life and lung function improvement. Both require an eosinophil count more than 300 for initiation, and Now, because both involve an injection and injection site reactions are the only most common adverse events, patients can be chosen to take either the twice a month therapy of Dupilumab or once a month therapy of Mepolizumab. But one thing is clear that the future of COPD is phenotype driven medicine. So before you start writing a prescription of Dupilumab and or Mepolizumab, it's very important to slow down. Gold asks us a very difficult question. It asks us if we are sure that the patient has truly failed inhaled therapy. Then it asks us to discuss adherence, to look at our inhaler technique one more time and probably change the device if needed, and look at the GOLD 4M approach, which basically makes it an inclusive approach considering all the morbidities also to manage COPD as a whole. So let's look at the evidence at a glance again. When you're comparing Dupilumab and Mepolizumab, you see that Dupilumab is working on dual IL-4 IL-13 blockade, and by blocking the IL-4 alpha subunit, it is inhibiting the signal of IL-4 and IL-13, thus reducing airway inflammation and mucus hypersecretion. While Mepolizumab is targeting IL-5 inhibition and binding directly to IL-5 to basically stop eosinophilic inflammation. The common biomarker used in both trials has been blood eosinophils more than 300, and all these trials have targeted only patients with type 2 inflammation using this threshold. The clinical profile has been moderate to severe COPD, and they're all typically older adults above 65 years of age on stable inhaled therapy. The primary outcomes in terms of annual exacerbation rate has been 30% in BOREAS, 34% in NOTUS with Dupilumab, and a lesser reduction per se as compared to Dupilumab, but a significant one also in Mepolizumab with 18 to 21% reduction. Talking about secondary outcomes, lung function and quality of life. If you look at the FEV1 gain that has been there in Dupilumab, the quality of life improvement has been noticed, but you have not seen as much of a gain in the Mepolizumab group. It has not been significant and less consistent also across the trials. If you look at the core efficacy data, then the hospitalization reduction has been significant in both these trials, and the other parameters have been variable. Now, coming to safety and monitoring, it's important to again acknowledge that while injection site reactions are the most common side effects, it's important to assess our patient's response over time. Fortunately, safety has not emerged as a major barrier, and we can give this injection safely. Coming to the 12-month review, it's important to review your patient. It's important to see if the patient is showing a clinical benefit after starting biological therapy and to consider stopping it if your patient is not improving. Remember the protocol. Initiating a biologic isn't a set it and forget it decision. You have to review it. If there is an improvement, you continue. If exacerbation has not improved, reassess. So, the take home message today is that biologicals are going to be a part and parcel of COPD management. It's important for us to now start learning about them. Eosinophils, for now, are going to guide selection, but the basics have to be prioritized. So, our patient, Mr. R, is a candidate of precision medicine, and the era of biologics has actually officially begun. If you find this material useful, subscribe to Pulmonology Read Aloud, and in future videos, we'll further go ahead and look at how we can walk through our real life clinical cases. Thank you, and keep watching and keep reading.